So look for a cause. Now, having finished PEG, let's talk briefly about constipation, which is a burden in that it's very common, even causes hospitalizations, and we all treat with medications. So the first mistake we make is to just believe the patient's statement. We believe patients, but the patient says, I'm constipated and I want something, and you start the, you don't try anything else except to give a medication, because this patient has already tried over-the-counter medications and is coming to you after he or she failed. So does it really fulfill the criteria of bowel movement less than 3 per week and the so-called Rome criteria, which has been revised periodically? This is the last updated criteria, where 25% of the time you need to have 2 or more of these problems. In the interest of time, I'm not going to read all of them, and this whole thing should have lasted at least 3 months. I've seen people, even doctors, sometimes tell me they move their bowels only 3 times a week. I've also seen the other extreme of some people moving their bowels twice a day, which doesn't mean it's diarrhea. It's all your habit and what you do and what you can do comfortably. So before you decide that this is constipation, look for all this. They say before you refer the patient to a gastroenterologist, check the calcium and thyroid. This is high on the list. And the potassium. Low potassiums can alter your bowel motility. So these are very simple, but thyroid and calcium are high on the list. And also to see whether there are any neuropsychiatric conditions like dementia, where it's going to be great difficulty in educating the patient. Parkinson's disease is notorious. So you've got a lot of these problems, including depression, which you need to look at. And my favorite, there are tons of medications which can cause you to get constipated. Patients buy calcium over the counter and are taking 3 pills a day. Surely that could be a cause. Iron preparations that you have prescribed. And look at all these medications. So one of the basic fundamentals is be careful about anticholinergics in older people. If I'm going to choose one group of medications, it's anticholinergics, which not only cause constipation, but they actually make your cognitive function worse. If you have mild cognitive impairment or mild dementia, that's going to get worse. So this is what you need to do. And you should look for alarm signs. One time a doctor in my hospital came to me. He was in medicine, a very bright doctor. He said, I'm concerned. And he told me, I've developed constipation of 1 month's duration, 1 month. I said, you need to get checked. Sudden onset, with or without weight loss, and rectal bleeding. Iron deficiency equals anemia and GI blood loss in many people. So when this person told me this, he, just to make a long story short, he had a huge mass. He had cancer, essentially. So sudden onset, instead of trying to do all kinds of measures, check for alarm features, check the few blood tests that I told you, and then get this person evaluated, because that could be a serious problem. So when I meant constipation, I meant long-standing, over 6 months, and there you're going to work on bowel habits, use of the gastrocolic reflex, which we all have. I have my gastrocolic reflex. In my case, it's triggered by coffee. So I have to get up and have my cup of coffee, and then I get my gastrocolic reflex to work. It could be a warm drink, it could be milk, it could be anything. And timing is everything on a regular basis. It could be every morning, and you try to evacuate by giving 10 to 15 minutes in the beginning. Later, it gets shorter. One patient said, I'm asleep all day. I'm a night worker. So that was interesting. I said, you could do this in the evening. Discourage routine laxative use, and you might need to call anybody. It's not always the gastroenterologist. There could be a psychiatrist involved in this patient. So I just want to tell you, it could be a cancer specialist, depending on your condition. So there's a lot of talk on what you should drink, but just drinking water is not going to do the trick. I've put it in small print. Just drinking water means if a patient comes into the hospital giving intravenous fluids, you're going to evacuate your bowels. It's not going to work. So you need to know it's a combination of activities, but exercise. That means move. After walking, after you finish your meals, walk. That's generally a good advice. Timing is ideally about 30 minutes after meals. It's even good for diabetes. That drops your blood sugar, incidentally. So physical activity doesn't have to be running, but walk. Walk after your meals. Drink enough fluids, not the wrong fluid, which is a lot of coffee. Coffee is fine. It may even be healthy, but not a lot. Consider certain foods or juices. Always fruits better than the juice. Prunes, even kiwi fruits are considered to be, they all have ingredients. It's not psychological, but they have ingredients which help the movement. In the case of prunes, it is phenolphthalein. So a combination will help. And rather than tell you add more medications, revise your medication regimen. We must have enough fiber intake. I mentioned this. America as a whole is inadequate. This is what we do. Normally less than 15 grams a day. It is considered to be one of the 5 nutrients of concern by the US dietary guidelines. We need a lot more of soluble and insoluble fiber. And at the minimum, we should be in that 20 to 30 grams. We don't need 50 or 60 grams per day of soluble and insoluble fiber. And you can do it in a bunch of ways. I did not utter the word medications. I would say fruits rather than juices, vegetables. A lot of items have fiber. If you must eat cereal, bran is rich in fiber. So these are some of the ways that you can encourage fiber. My favorite is have a bowl of milk with bran cereal, bran, sliced bananas or some fruits, put them in the cereal, and it is quite delicious. And I honestly have tried this a lot. Many nursing homes give combinations for breakfast, but the principle is to increase your fiber intake. Question number 4. A 90-year-old frail nursing home resident is too deconditioned to get out of bed. She has a history of chronic constipation and has been a long-standing laxative user, which is ineffective. Her abdomen is distended. The staff mentioned that she has small amounts of liquid stools. Now, whenever people mention that, we think of C. diff. So is that what you're going to look for? Are you going to do a rectal exam? Or you're going to alter the fiber intake? Or you're going to give an enema followed by osmotic laxatives? What are you going to do? This is liquid stools in a chronically constipated person with abdominal distension. So really, this patient has what is known as fecal impaction and factitious diarrhea. I recall seeing such a case when I started life as a resident in this country as a PGY1. I still haven't forgotten how my senior resident said, give an enema, and I didn't know why. It's hard stools, and the stools liquefy above and seep down. It is solid impacted stools, but the stools above putrefied and seeping down. And that is what is fecal impaction or factitious diarrhea. Now, just giving a laxative is not enough. First of all, you have to fragment the feces. You will need to do a rectal exam and clear that. And now develop a long-term bowel regimen. It's not going to be immediately giving a laxative. So this is such a chronic problem that the bowels have lost their muscle and nerve function, and this is not going to be easy to reverse. So you should start with a rectal exam and then see what you can do as a long-term strategy. This is an extreme case, factitious diarrhea. My last comment, and in the interest of time, I'll be brief. We all need to be aware of anemia. And here I'm going to say that 1/3 of all anemias, this is US statistics from people 65 and older, NHANES data. 1/3 of all anemias is nutritional, which means the gastrointestinal tract. I think I told you whenever you have iron deficiency, you should look for a cause, but you could determine this 1/3. 1/3 results from some forms of disease, and 1/3 will be hard to figure out. So anemia is not just a number, it has consequences. It results from a cause. It's a serious problem. Sometimes it may be cancer, sometimes it might be bleeding peptic ulcer, but it's from a cause and it worsens all other functions, causes you to be weak, causes you to get depressed. You cannot walk, your gait is impaired, your heart is disordered, there is LVH, you get depressed, and now it even predisposes to CKD. So this is a simple slide, tells you what all can occur if you become anemic. But these anemias are not so simple. This is B12 deficiency, and rather than tell you a simple explanation, I just want to tell you B12 absorption is very complex. There's a huge numbers of steps, and that's why B12 deficiency is so common. But all of them are in the GI tract. I want you to know that half of B12 deficiency is from failure to split B12 from food protein. Half. It's not pernicious anemia. So it's a very complex problem, and therefore it's very common. With regards to treatment of cobalamin deficiency, all of the following are true, except vitamin B12 deficiency can be prevented by regular use of vitamins containing B12. B12 in large doses corrects most causes, including PA, pernicious anemia. Correction reverses hematological manifestations, but not neurological deficits. And B12 must be administered routinely for anticipated deficiency following bariatric surgery. This is just a question. So if you look at all these causes of B12 deficiency, I'll just say this is the most common: food cobalamin malabsorption, where we failed to promote the split of cobalamin from food-bound protein outside our body. When we take in, we need to split it, or we don't do it. PPIs also cause B12 deficiency. This is a study that I demonstrated. This was actually the first study that was done over 6 years. And you see the B12 levels come down on chronic PPI users. Unlike folate, so this is green, folate, which is widely dispersed in fruits, beyond green leafies, B12 distribution in foods is sparse. You need to be aware of this. So it's harder to get B12 just from food alone. Whereas you can get folate, you can by good food habits. So the answer is you can't just prevent it by using multivitamins. You need to go further. You need large doses of vitamins. And if you do it in time, you can reverse the hematological manifestations, but not the neurological deficits. You also should get B12 routinely after bariatric surgery. My one comment before I go on to question is that iron deficiency always warrants evaluation. If your patient is iron deficient, look for a cause. It could be something serious. So with that, in the interest of time, I'm going to stop. We have started now the newest recommendation. I just threw this in because this just came out. Start looking for colorectal cancer screening earlier in life. We do it between 50 and 75. The age is now lowered to from 45 years. It's a grade B recommendation. So with that, I'm going to stop. I'm sorry I rushed the last few slides in view of time, but I'll now take any questions or comments as you might regulate.